Progesterone is produced primarily in the ovaries, but also in by the placenta and the adrenal cortex. It's synthesized from cholesterol and rapidly metabolized by the liver. LH is the primary regulator of progesterone secretion. In early pregnancy, HCG from the placenta maintains the corpus luteum progesterone production until the placenta starts to take over. Progesterone prepares and maintains the endometrium for implantation and sustains early pregnancy. Its levels peak in the luteal phase and fall just before menses, and it also promotes breast glandular development and increases basal body temperature, which is a key feature used in fertility charting. During pregnancy, progesterone rises tenfold compared to non-pregnant levels. Progesterone assays can help confirm ovulation, evaluate luteal phase adequacy, and monitor hormone replacement therapy. In early pregnancy, serial progesterone measurements, often paired with HCG, can help determine viability or detect possible ectopic pregnancy, as low progesterone in pregnancy may signal threatened miscarriage, while elevated levels can indicate molar pregnancy or even adrenal overproduction. Throughout pregnancy, hormone production shifts dramatically. Estradiol and progesterone increase steadily as the placenta becomes the primary endocrine organ. These hormones are essential for maintaining the uterine lining, supporting fetal development, and suppressing the maternal immune response to prevent fetal rejection. Their steady rise also contributes to physiologic changes like increased blood volume, breast development, and GI motility changes. This slide just shows you the sustained elevation of estrogen and progesterone in pregnancy. Such high levels are going to suppress LH and FSH through negative feedback, which prevents additional ovulation. They also drive key physiologic adaptations, like we mentioned, including increased uterine blood flow, enlargement of the uterus, and breast tissue maturation in preparation for lactation. Clinically, these elevated hormone levels explain common pregnancy symptoms such as nausea, fatigue, and mood changes. During a normal menstrual cycle, progesterone stays very low during the follicular phase and begins to rise after ovulation and will peak in the mid-luteal phase. This pattern helps to confirm whether ovulation actually occurred. Tracking progesterone across the cycle is a fundamental tool in infertility workups. If progesterone does not rise appropriately, it suggests anovulation or a luteal phase defect. Progesterone levels will significantly rise in pregnancy with a well-defined trimester range. The first trimester relies heavily on the corpus luteum, but by the second trimester, the placenta takes over production. These values can help clinicians assess pregnancy viability. Low progesterone in early pregnancy can indicate risk of miscarriage or ectopic implantation, while very high values reflect maybe a molar pregnancy. Progesterone after menopause, progesterone levels will fall to very low or undetectable levels because ovulation ceases and the corpus luteum is no longer formed. Low progesterone contributes to symptoms such as night sweats, sleep disturbances, and irregular bleeding during perimenopause. It's also why postmenopausal bleeding always requires evaluation, as it should not occur in the absence of progesterone cycling. High progesterone can indicate pregnancy, ovarian or adrenal tumors, congenital adrenal hyperplasia, or molar pregnancy. Low progesterone is associated with anovulation and luteal phase defects. In pregnancy, low progesterone can be a warning sign of threatened miscarriage. These interpretations are always paired with symptoms and timing within the menstrual cycle. When we come back, we will look at progesterone and we'll look at prolactin.